Welcome to this edition of MBBS class. Today we are going to discuss juvenile idiopathic arthritis. As I always say, this class is not a replacement for your reading. This will help you to understand what you read much better. So after this class, you must definitely read your textbook, and two benefits. One, you will understand it much better. The grasping will be much better. And the second thing is you will be able to avoid what is unnecessary that is given in the textbook. So what is JIA? It is a chronic autoimmune disease, and it is not of a single etiology. Heterogeneous group of disorders characterized by chronic arthritis. And it is the most common rheumatic disorder of childhood. And it has got a potential to have long-term disability and morbidity, and hence the importance of treating in time. So, in short, the definition of JIA would be arthritis involving one or more joints that is occurring before the age of 16 years, and that is why it is called juvenile, and persists for more than 6 weeks without any other known cause. So that is juvenile rheumatoid arthritis. So it should affect more than one or more joints. This disease must start before 16 years of age to call it as a juvenile disease. And the whole process should persist for more than 6 weeks to call it as juvenile rheumatoid arthritis. And all the other causes must be excluded. And one characteristic finding is early morning stiffness, and you are very stiff in the morning and it improves as the day progresses. And the sex predilection is there. Females are more affected than males. Exceptions you need not know now. We will discuss in due course. So rheumatoid arthritis, females are more affected. So what is the criteria for diagnosis of juvenile rheumatoid arthritis? As I said already, onset should be less than 16 years of age. Arthritis. And what is arthritis? Swelling or effusion of the joint, and presence of two or more of the following, that is limitation of range of movement, tenderness or pain on movement, and increased warmth in more than one joint. It need not be present in each and every joint. So that is the first criteria, arthritis. Second is duration of disease, that is more than 6 weeks, which I discussed in the previous slide. And the onset type will determine what are the subclassifications of this disease. Polyarticular JIA, if more than 4 joints, that is equal to or more than 5 joints inflamed. You call it OLIGOARTICULAR JIA if 4 or less joints are inflamed. And you call it systemic onset disease where the predominant symptom is fever and other systemic symptoms. We will come to these things in detail. Now, regarding the etiopathogenesis, first of all, it is not understood as of yet. There is an immunological susceptibility or a genetic susceptibility in an individual where some external factors play a role to initiate the event. For example, you are genetically prone to the disease, but there are so many genetically prone people who are not having rheumatoid arthritis. So in addition to your genetic or immunological susceptibility, you need an external initiating factor that triggers this disease. So it is an interplay between these two. And one example of this genetic is HLA B27, which is associated with a typical oligoarticular juvenile idiopathic arthritis, which we will come to later on. So you'll understand it better. And non-genetic triggers are also there. For example, viral infection, Epstein-Barr virus, parvovirus, rubella, so many. And the disease occurs as a product of dysregulation of immune system in which T cells play a very significant role. Cytokines released by T cells. Cytokines means tumor necrosis factor alpha, interleukin 1, interleukin 6, etc., activated against the synovial antigen along with activated B cell and complement system causes immune complex deposition and inflammation of the synovium and progressive erosion of the articular cartilage and bone erosion. So it is a cytokine damage. And there is a particular subtype of JIA called systemic onset JIA, that is SOGIA, which is actually an autoinflammatory disorder. The details of that we will not go in undergraduate level, so we'll stop there. Polyarticular. We said what is juvenile idiopathic arthritis. Juvenile idiopathic arthritis is an arthritis of more than one or more joint lasting more than 6 weeks, where no other cause could be found. So in that there are subclassifications. One is polyarticular, which means 5 or more joints are affected in the first 6 months of the illness. In this, there are 2 classifications. One subclass will be rheumatoid factor positive, another subclass will be rheumatoid factor negative. The second group is oligoarticular juvenile idiopathic arthritis, of which there is one subclass which is called enthesitis related JIA. Enthesitis means tendon insertions. So there is pain and swelling at the tendon insertion. For example, Achilles tendon insertion at our back of the foot, that becomes swollen, inflamed and painful. The next one would be psoriatic arthritis, where you have psoriasis and along with that you have arthritis. And lastly, systemic onset juvenile idiopathic arthritis. So those are the major classifications. That is polyarticular, oligoarticular, psoriatic and SOGIA. So that is clear. No? Subclassification will come to still once more. Juvenile idiopathic arthritis, polyarticular, what is it? In the previous slide, I said there are 2 types. One is rheumatoid factor positive, one is rheumatoid factor negative. So JIA, polyarticular rheumatoid factor positive type, that is an equivalent of adult rheumatoid arthritis that you are familiar with. So what is adult rheumatoid arthritis? Small joints are involved, or the proximal interphalangeal joint, metacarpophalangeal joint, wrist joint, all these things are affected. So since it is a child equivalent of adult rheumatoid arthritis, you can simply imagine it affects the quite old child, very near to adolescent or adult. So the age group is older child. And 2 things are, one, rheumatoid factor positive. Second thing, rheumatoid nodules are there. And where do you find this nodule? In the elbow, in the spine, Achilles, etc., or over the knuckles. So rheumatoid nodule, its presence indicates a more severe disease. So what is juvenile rheumatoid arthritis or juvenile idiopathic arthritis, polyarticular type 1? It means it is rheumatoid, it is like an adult rheumatoid arthritis. Small joints are involved, older child is involved, rheumatoid factor is positive and rheumatoid nodule is positive. So that is clear. Now we will come to the next. This is the polyarticular type only, but here the rheumatoid factor is negative, which means it affects children of younger age group because it is different from adult type. So younger age group, that is toddler age groups, children are affected. And in addition, the rheumatoid factor is negative, the nodules, rheumatoid nodules are unlikely. So that is the difference between these 2. So what is common between these 2? Both are polyarticular. 5 or more joints are involved in the first 6 months of disease. That is a common thing. Second common thing is a lot of small joints are affected. Although large joint can be affected, small joints are affected. But otherwise, they are different. One is the former one. The first one that I described is rheumatoid factor positive and rheumatoid nodule positive. This one is rheumatoid factor negative, rheumatoid nodule negative, and it affects younger children. rather than vulvar. Now coming to oligoarticular or the so-called quasi-articular JIA, which means limited number of joints are involved. That is up to 4 joints in the first 6 months of illness. This is the typical juvenile idiopathic arthritis of a child. The peak age is toddler, 2 to 4 or 2 to 5 years. Generally, all rheumatoid arthritis, except 1 or 2, which I'll come to, are affecting the females predominantly. And oligoarticular JIA is diagonally opposite to the polyarticular JIA. Polyarticular, we said, small joints are involved, large, bigger children are involved. You will have rheumatoid factor positivity, rheumatoid nodule. Here, small children are affected, large joints are affected. For example, knee joint. And in addition, there are no rheumatoid nodules. And rheumatoid factor is negative. And in addition, it has got uveitis or the so-called iridocyclitis, and ANA appears to be positive. So those are the 2 additional. Now, oligoarticular or quasi-articular JIA has got a variant that is called enthesitis-related arthritis, which means our insertion of tendons gets swollen up. So you have swelling and pain at the insertion of tendons. In addition, there is a predominant involvement of sacroiliac joints also. And axial skeleton may be involved. Spondylitis is possible, and actually this is a child equivalent of ankylosing spondylitis of adult. So these are the peculiarities, and this is the only JIA where males are affected. All other JIA, females are affected. But this is the only juvenile idiopathic arthritis where male is affected. And association with HLA-B27 is up to 80%. So it is almost always associated. And arthritis may affect any joint, but peculiar to this subtype is sacroiliitis and spondylitis and enthesitis. So this affects boys and older boys, older age group boys. So that is peculiar in this, and it has got extra articular manifestation. Extra articular manifestation like uveitis is also present in oligoarticular juvenile idiopathic arthritis. So enthesitis-related arthritis can be summed up like this. It is an arthritis in a HLA-B27 positive school-age boy with a family history of ankylosing spondylitis or sacroiliitis or enthesitis-related arthritis. So that will sum up the diagnostic criteria for enthesitis-related arthritis. So enthesitis-related arthritis is basically a oligoarticular JIA, but has a peculiarity that HLA-B27 is positive. Boys are more affected. Say back, sacroiliac joint and spine, ankylosing spondylitis are more likely to be associated, and tendon insertions are likely to be painful. So that is the difference. Otherwise, it is a oligoarticular from rheumatoid arthritis or JIA. Now, this is the most serious subtype of juvenile idiopathic arthritis. That is systemic onset juvenile idiopathic arthritis, otherwise called SOJIA, SOJIA. And what is the presentation? Fever, fever, and fever. No cause could be found. You investigate, nothing is found, but fever simply goes on and on and on. So that is the characteristic of juvenile idiopathic arthritis of this systemic variety. Now, arthritis involves more than one joint. That is, any juvenile idiopathic arthritis, the joint one or more is affected, and the same applies here also. And the type of arthritis is classically polyarticular and destructive. Joint destruction can happen. But in Sogia, generally arthritis is not very apparent because the child is running such a high fever, nobody notices arthritis. So fever, that is the presentation. So fever of at least 2 weeks duration, daily or twice a day, spikes, accompanied by one or more of the features. One is, along with fever, you can have an evanescent rash, which means it appears and then disappears within hours. It's a salmon-colored rash, faint rash, usually in the body. And then visceral involvement, like lymphadenopathy, hepatomegaly, splenomegaly, and serositis, pericarditis, pleuritis. Now, this is another sub-classification of JIA, that is psoriatic arthritis. Somebody having psoriasis, having an arthritis also is psoriatic arthritis. It's as simple as that. But the psoriatic manifestation may come months or years after the arthritis manifestation, and there is the confusion. So we depend on family history. Suppose there is somebody in the family with psoriasis, somebody in the family with nail pitting, onycholysis, then we suspect psoriatic arthritis even before the skin manifestation comes in the child. So is that clear? So that is the point that I said. Arthritis may precede skin manifestation by years. Now, what is the type of arthritis in psoriatic? Any type. It can be polyarticular, it can be polyarticular. It can be asymmetric, it can be symmetric. It can be small joint, it can be medial joint. It can affect axial joint as well. And extra articular manifestation, for example, uveitis, psoriatic skin lesions, nail pitting, onycholysis, etc. So that is psoriatic arthritis. Clinical examination of juvenile idiopathic arthritis, that is not given in many textbooks. If you are interested, you can refer to my clinical examination book. That is more important for postgraduate, not really for undergraduate. Now we recapitulate the classification of juvenile idiopathic arthritis. There is a polyarticular variety, posi or oligoarticular variety. There is a psoriasis-related variety, and Sogia, systemic onset JIA. Polyarticular can be rheumatoid factor positive, rheumatoid factor negative. Rheumatoid factor positive polyarticular is adult type of rheumatoid arthritis, which means it comes in a very much older child, affects small joints. Of course, larger joints can be involved, but typically small joints are involved. You can have rheumatoid nodules. If it is a rheumatoid factor negative polyarticular JIA, then these things are not there. That is, small child is affected. The larger joints are more commonly affected. Rheumatoid factor is negative, and there is no rheumatoid. Now coming to the next group, that is oligoarticular or quasi-articular, where up to 4 joints can be affected within the first 6 months. Large joint is affected, especially knee joint. There is no rheumatoid nodule. There is rheumatoid factor is negative, but 2 things are positive. One is uveitis is there, likely, and ANA positivity is likely. So that is oligoarticular. And another subtype of this oligoarticular is called enthesitis related oligoarticular JIA. Enthesitis related means in this particular variety, tender insertions are painful. And as compared to the other oligoarticular JIA, this is diagonally opposite. Boys are more affected. Tendon insertions are affected. Sacroiliac joints are affected. Spondyloarticular spondylitis can be there. So that way it is totally different from the other oligoarticular. And the next one is the psoriasis related, where you find either a family history or the personal history of nail changes or skin changes along with arthritis. And in psoriatic JIA also you can have uveitis and other system involved. Lastly, systemic onset juvenile idiopathic arthritis, which is a fever predominant arthritis. And the fever goes on for weeks. And it can have organ involvement. Lymphadenopathy, hepatomegaly, splenomegaly, etc. Now, what are the complications of JIA? One is iridocyclitis or the so-called uveitis. The problem is normally uveitis could be painful and you will detect immediately. Here, it is simply painless. Some redness may be there. So unless we do a ophthalmic examination by slit lamp, you will miss. And once you miss it, it can lead on to permanent damage to the eye or vision. So that is the importance of periodic eye checkups in juvenile idiopathic arthritis. Second complication is joint damage. The joint cartilage can be damaged. The joint space gets narrowed. There can even be ankylosis. The movement may be so restricted that there may be hardly any joint. Then growth retardation. Because if the growing end of the bone is affected, then that particular area will not grow. So asymmetric growth retardation. Osteopenia, that is, the bone becomes thinner and thinner and thinner. Less of calcium is there in the bone. That is because the disease, the joint is less used, so less of calcium gets deposited there. Moreover, we use steroid occasionally for JIA. That will also affect the calcium deposition, so osteopenia. And chronic temporomandibular disease will, suppose this temporomandibular joint is affected, then naturally this part will grow, but this part is held here, will not grow. So the chin will go inward, so-called micronathia. And the last is the most dangerous thing, the macrophage activation syndrome. That is not very important for undergraduates, but still it is an auto-inflammatory disorder. It could be fatal. That is the most important thing. Rapid onset of high persistent fever. This actually occurs in SOGIA, systemic onset juvenile idiopathic arthritis. So your fever was under control for some time, and now simply fever recurs and just refuses to come down. And lymphadenopathy comes back, hepatosplenomegaly comes back, the blood counts drop, there is hepatic dysfunction, thrombocytopenia, leukopenia, the liver enzymes are elevated, coagulation profile is deranged, and the fibrinogen drops, albumin drops, and most important for undergraduate, ESR drops. So in a juvenile idiopathic arthritis, especially SOGIA, if the fever is high and persisting, there is no reason why ESR should come down. Suppose your disease is getting under control, the ESR will come down. But if the fever is high and persisting and the ESR is coming down, that is very dangerous. So that is one clue that we can all take, because it is not a sophisticated investigation. The other investigation that is sent for this macrophage activation syndrome is elevation of ferritin and triglyceride. That you need not worry, that is for the postgraduate to know. What you have to know is there is a complication called macrophage activation syndrome, which is self-destructive, which can be fatal, and it need be picked up very early. And it is picked up early by falling ESR and falling counts in a child who is running high fever. A child who is having juvenile idiopathic arthritis and running high fever, not any child having high fever. Now, what are the differential diagnoses? One is septic arthritis, but septic arthritis generally will be limited to one joint. It is very unlikely that so many joints are affected in septic arthritis. Tubercular arthritis, we all know. One, it is a very late manifestation of TB. So, in a child, TB arthritis is rare. And second, of course, you can do Manto, you can do CBNAT, and things of that sort. Rheumatic fever, we know Jones criteria. You apply Jones criteria and see whether it is fitting rheumatic fever or not. Osteomyelitis, the tenderness is actually over the bone rather than the joint. And then you may get a history of trauma, which may have initiated osteomyelitis. And the malignancy, the leukemia, presenting as arthritis is extremely important and should not be missed. And that's why in investigation, the importance of periplasm. Hemophilia, we all know, occurs in males, and it is joint bleed. So it presents as joint swelling and the joint warmth. But again, multiple joints is unlikely. Generally, one joint is important. And transient synovitis is a phenomenon following, say, for example, an unrelated viral infection. You have a slight effusion and restriction of movement of joint for a few days, usually of the hip joint. So, what lab investigation? Again, we will do the lab investigations routinely, of which ESR and CRP are likely to be elevated in an active disease. Peripheral smear we must do for ruling out leukemia. Rheumatoid factor is positive only in polyarticular type, in a bigger child. ANA is positive in oligoarticular rheumatoid arthritis. HLA-B27 is positive in enthesitis related JIE. End organ evaluation, especially in case of complication, you must go for renal function and liver function. X-ray, we will find the erosions, osteopenia, and the joint space may be narrow. And MRIs gives more information compared to X-ray, because X-ray information is available only if there is significant joint involvement. Synovial aspiration and biopsy can be considered. Synovial aspiration, actually what is happening is inflammation. And once there is inflammation, there will be polymorph there. So joint fluid will yield a lot of polymorph. That is not indicative of infection. It indicates inflammation. So inflammation can be because of trauma, because of autoimmune, because of infection. So how will you differentiate the inflammation of JIA from inflammation of septic arthritis? You gram stain, there is no organism in JIA. You do culture, there is no organism in JIA. So that's how we differentiate. Slit lamp examination of eye is a must for all cases of juvenile idiopathic arthritis. Mando if TB is a consideration. And macrophage activation syndrome, if it comes, then sophisticated investigations you need. Now the management. Management is multidisciplinary approach. Drugs, physical and occupational therapy, ophthalmic evaluation, rheumatologist if available, then family education, how to deal with the disease. The first line is non-steroidal anti-inflammatory agent, and the commonest thing that we use is naproxen. The other thing that can be used is ibuprofen. Aspirin was the chosen drug of yesteryears. Nowadays, we are not very favorable to aspirin because of side effects. Naproxen is much better tolerated. Then if one or two joints alone are involved, intra-articular steroid will have a dramatic effect, because steroid is an anti-inflammatory far superior to any other drug. Then when there are exacerbations, we will need systemic steroid off and on. that can be given often, not continuously. You have to, once you start steroid, you have to withdraw it. If there is uveitis, then you can use topical steroid and atropine drops. Then the so-called disease-modifying drug, because non-steroidal anti-inflammatory drugs will reduce the inflammation and reduce the pain, but the disease process is not affected. So disease-modifying drug is methotrexate and hydroxychloroquine, the two things that are commonly used. So that is a very slow-acting drug. So you always need a non-steroidal anti-inflammatory drug or sometimes steroid. But over a period of time, this disease-modifying drugs takes over. So the dose of other drugs can be brought down or even taken off, and the child may be maintained on disease-modifying drugs. So disease-modifying drugs are essential to prevent joint damage. But for an immediate relief, this is no use. For that, you have to either go for NSAID or steroid. Then because there is less of movement, because joints are all painful, it's not moving much, so calcium deposition is affected, and hence vitamin D and calcium are generally in physiological doses are generally sub. Suppose disease-modifying drugs are not effective, or in a very rarely, it may be that it doesn't control it. In which case, the biological agents are used. What is meant by biological agent? It is tumor necrosis factor antagonists. For example, etanercept, infliximab, adalimumab. So you need to know one or two names just for your theory. It's not important for MBBS. The other biological agent available is interleukin antagonists, because in etiopathogenesis we said these interleukins are secreted and that produces inflammation. So if you take care of these interleukins, that inflammation will come down. So interleukin 1 antagonist is anakinra. Interleukin 6 antagonist is tocilizumab. Now physiotherapy is a very important thing, because immediately when the joint is excruciatingly painful, you will not do any physiotherapy. You give rest. But once it becomes movable, we start physiotherapy as early as possible to keep the range of movement, also to avoid osteopenia. And for the immediate relief of pain, we can use heat or cold, whichever brings relief. And range of movement exercises, muscle strengthening exercise, that is isometric. You just contract the muscle without actually moving the joint. Then swimming is very good, because the buoyancy of the water will keep you up. So much so, the pain and range of movements are much better with swimming. And when we are sleeping, we may need resting splints, because otherwise the joints may get fixed in unsuitable positions. So in the position of function, we can give splints during sleep. And another important thing about sleep is, during sleep, our muscle tone comes down. So much so, the muscle that was keeping the joint apart becomes relaxed, so that the surfaces rub together and produce pain. So that is the reason for children complaining of pain at night. Now, what is the prognosis? Prognosis, most of them, more than 50%, will remit after multiple recurrences. But the typical, I said, the typical childhood JIA is pauci-articular or oligoarticular, which is more than 50%. There, the prognosis is very good. Only thing is, we must make sure that uveitis has not destroyed the eye. So as long as that is taken care of, then the prognosis is fairly good. The other things like enthesitis-related arthritis or systemic onset. All these things, the prognosis is variable, not as good as oligo or post-articular JIA. But fortunately, most of the JIA in childhood is post-articular, and that has got good prognosis. Thank you. Thank you for listening. Now you will have to go back, read, and then if you want, you can come back to this presentation again and listen once more.